another ECIST Bite-Size podcast. My name is Erika McGinnes. I'm an improvement manager with the Emergency Care Improvement Support Team, and I'm joined today by two colleagues from Sherwood Forest who are here to talk to us about their ambulance handover improvement. Ben and Richard, would you like to say hello?
Yeah, hi, Ben Owens. I'm an ED consultant with Sherwood Forest and I'm an ECIST clinical associate.
Yeah, hello, I'm Richard Clarkson. I'm a divisional head of nursing for Manager Care. I'm an ED nurse by background, and I'm also the head of service for ED. And like Ben, I do some clinical associate work for ECIST as well.
Thank you both, and thank you very much for joining us to talk about your ambulance handover improvement work over the last few years. Ambulance handover is obviously quite in the spotlight at the minute, and I know everybody's considering their opportunities for improvement. Ben, just in terms of context and statistics, can you share with those listening, I guess, some key facts and figures?
Yeah, certainly. So as a front door, we're seeing about 450 patients a day. About 22% go to a co-located primary care stream. Of that, we're getting about 100 ambulances a day, so about 3,000 ambulances a month. And our SDEC unit is seeing about 1,100 patients a month. Sorry.
That's fairly busy, isn't it? Richard, can we talk about what that looks like and feels like on a monthly basis then in terms of performance?
Of course, yes. Like Ben said, we see around 100 ambulances a day. Sometimes we go up to 120, which can be the sort of really challenging, 120 and 25 a day. But as a rule, monthly figures, we see about 45% to 48% of those crews turn around within 15 minutes, and the rest are sort of way under half an hour. We do see about 3 to 4% a month that are way over half an hour, and then we see a very small percent, about 6 patients a month, that the data suggests way over an hour. We do data quality on all those, and actually what we find is that it's just when we haven't used the ambulance arrival screen or there's been a DQ issue. So yeah, it's very few.
Thank you. Can we talk a little bit about your process? So what does that process look like once a patient arrives in an ambulance to your emergency department? What happens to them?
Yeah, so obviously I think the first important thing is to give the staff a clear process of how to receive ambulances into the department. There's multiple areas in any ED, worse since COVID, with red zones and such like. So we give the staff a clear process, and we of course got the ambulance arrival screens, which really helps us to not only know who's there, but who's looming out in the community pending a conveyance into the hospital. So yeah, the ambulances will arrive into majors, which is predominantly where most of the crews are received. From there, we don't have a pit stop, so it's probably quite controversial for some people to get their head around, but we don't have a pit stop. We see a pit stopping as a process, not a place. All the crews will be greeted very, very briefly by the nurse in charge, just to get a brief history, whilst at the same time they're booking in, so they've been registered into our system. So the arrival time is when they arrive. When the clock starts, the nurse in charge will then allocate them a cubicle based on what the needs of the patient may be. Initial assessment by the nurse, and they will go on to what we call our senior streaming process to sort of front load investigations further.
So if I understand you correctly, Richard, that means that handover is everybody's business in the department.
Everybody's business.
And what has allowed you to facilitate that in terms of change with your teams? So are there any enablers you would particularly call out?
Yeah, I think obviously, we need, like I said, having the clear processes. We need to make sure that we are front loading the investigations. So a robust senior streaming policy process to enable sort of CTs and blood tests and x-rays and that kind of thing to be done at the first point of contact. So we have a clear process with the nursing staff to speak to consultants or senior registrars to get that done. We also make sure that we stream out at every given opportunity to our SDEC, like Ben mentioned, or our primary care service. The nurses, with all the will in the world, can't turn the crews around unless the clinicians make the decisions to get people out. Even with exit block, there are some patients that we control that need to go home. So we work with the clinicians to make sure that process is in place to create maximised space, even the most of overcrowding. I think the main thing is to work with the nursing staff to get buy-in. The nursing staff really need to understand that our responsibility is not just for you know, the lady or the gent in front of us with the broken hip or the pneumonia. It's for the little old lady who is lay on the floor in a bungalow out in the community. To have a sense of ownership for the wider community and make sure that patients, you know, we don't leave patients on ambulance trolleys waiting to hand over. We get the ball started and get the patient in and get the treatment commenced. So I think having that constant buy-in and constant high on the agenda for the department and the organisation is absolutely essential. Constantly reinforcing good practice, constantly reminding the team how important it is and to take ownership for the wider community, and praise. You know, we keep a close track on this every day. So we put constant comms out, we feed back the monthly data, so the staff have got a real sense of pride of this, given how hard it's been, you know, since we've come from being not so good to being great. At this, it's really important we praise the staff, thank them, and sort of make them know that this is outstanding work.
Thank you. Ben, anything you would want to add from, I guess, a consultant's point of view in that respect?
Yeah, I think one of the things that is really important is that we work with EMAS closely, and actually this is more of a nursing thing, but actually, so when a crew arrives, when they handover, the nurse and the crew will go to the handover screen together and they put their pin in, our nurse puts our pin in, so we know the time, we're agreeing the time, and it sort of drives it a little bit with the crews as well. We meet with EMAS monthly and work with them on that.
Can Richard just talk us through the double pinning process for crews to make sure they're all clear?
Yeah, definitely. So obviously this is the ambulance arrival screen. When we've got crews that are waiting handover, it will be on the board and quite visible, so the nurse in charge can track that. Once handover has taken place, the nurse and the paramedic or the tech will go to the screen, click on the crew that's here, and we will press handover. The crew will have their individual pin, which is, you know, sort of individual to that person, and there's a generic one for the hospital, for the department. Both put the pin in, and that will then call the crew as clear. The crew will then be marked as handover on the board. The nurse goes back to the patient, and the crew goes back to the next job.
I think it's really important that every bed meeting, ambulance handover times are discussed as one of the first items. Actually, what do you need help with that? What can we do with that? So it's owned by the organisation. It's really important, and I think the other real thing, as Richard says, is it's ownership by the nurses, also the medics, and actually when a crew arrives, someone will go, there's a crew here, what we're going to do. So it's a departmental thing, and how we own those patients in the community who are, I think, the way as soon as they call the ambulance, they're our patients.
That's really, really helpful, and I guess sets the context of how important it is, not just to a small group of staff in the department, but to everybody who's happened to be on shift on that particular day. We all know how challenging it is in the emergency departments right now. So Ben, what happens when you have exit block? Are there things that, I guess, as an ED team, you feel you can perhaps control more directly?
Yeah, I think the first thing, as Richard says, is decision making. So 75% of our patients go home, which means we can control how long they spend in the department. So that front loading of investigations, treatments, doing huddles and making decisions, streaming out every opportunity, so it's the right patients to the right place. So our STEC unit is seeing 1,100 a month, as I say, primary care stream.
Yes, for about 8 years we've had a co-located service, which is behind us now. They see about 22% of our patients, which I think is about 200,000 over the 8 years. They'll see pretty much anything that doesn't need an X-ray. So patients that need simple blood tests they may see. We even push things like hemolyzed high potassiums, high INRs. They don't see any injuries. They are seeing head injuries, but no limb injuries. That's done separately. We meet with them weekly. We started at about 8%, and that's gone up to 22%. We meet every week with them. We look at two lots of things. We look at the patients who could have gone from ED but didn't, and we look at the ones who were sent to primary care and returned back. And in doing that, we've constantly refined the process. So we pick up patient groups and that sort of thing, where missed opportunities or perhaps people we shouldn't have sent, not the best patient pathway.
But also post-op patients going to the surgeons, people with certain, so early pregnancy bleeding, going to gynae, so actually the right place first time. So controlling what you can control, really important. One of the things we do that is someone would find more controversial is at times we will put 2 people into a cubicle, obviously with a screen between, and the reason is there's a finite amount of space in the department. We have got exit block, and that's come on the last 9 months. Sort of 50 bed breaches a day, and one of our mitigations is to utilise resus space to hand over, but also to put 2 people in a cubicle at times, which is not what we want to do. But actually, it's better to have 2. At our heads, it's better to have 2 people in a cubicle for a short period of time, than it is to have a person in the streets with a fractured hip lying on the floor
Sure.
in pain. Of the two evils, the lesser one by far is to do that. So we do that, and it's about we really optimise fit to sit as well. So we really push hard on fit to sit patients and ambulatory patients as well.
Richard, is there anything you would want to add to that from a nursing perspective?
Yeah, I think, like Ben said, it's really important to understand, the overcrowding in ED is happening up and down the country. And I think, whilst it is probably controversial that we do put 2 patients in cubicles that are big enough, we're not sending patients on top of one another. There is a screen between them, and we are maintaining privacy the absolute best we can. But I think, again, it's installing that into the team that actually, you won't, whilst being 2 patients in the cubicle is uncomfortable, probably not the best patient experience, but you won't die from that. You will die if you're sitting in an ambulance outside that you are not having sepsis treatment. Patients in the ambulances don't always get treatment. Some trusts, I guess, are going out there and starting treatment, but there are patients in the community that are not getting treatment, are not receiving what they need, and are being left, and that is the bigger risk to us. And we've got our heads in gear to own that, I think, which is essential, and the team are brought into it.
So
just the final point I think to make is that we want the patients as soon as possible. Most frail old people that end up hitting the ED after 11 in the morning through till 7 or 8 at night, if you've got a 2-hour handover delay, that 5 p.m. patient is a 7 p.m. patient, the 7 p.m. patient is a 9 p.m. patient in ED. And actually trying to get that patient home for an extra 2 hours on the floor at 9 p.m. is so much harder than getting home at 7 p.m. when they've had less than 2 hours less on the floor. It's clearly our frailty team are here, our SDEC is open, we want them as soon as possible.
The sooner the better. I absolutely agree with you, Ben. But I guess you're also perhaps both saying that there's something about considering ambulance handover improvement in the context of improvement across the wider department, because, as you say, in order to be able to readily receive ambulances, you need to do your best to decompress the department more widely as well, don't you?
It's about controlling what you can control and prioritising that person in the community who's getting no healthcare.
Sure.
Versus the ones who are with us who are getting some.
I think the important thing is just for the staff is to know that everybody out there that's ringing an ambulance, or everybody that's stuck in the corridor waiting to hand over, is somebody's grandma, is somebody's grandfather, is somebody's loved one, is somebody's child, and that's the mindset we're in. And I personally wouldn't sleep at night if I felt my grandma was waiting for an ambulance all those hours. You hear such horror stories, and it's within our control to make improvements for that.
Agree. A question for both of you. How have you managed to keep the process sustainable? So you said that this is a journey that has kind of taken a couple of years, but how have you made it stick, Ben?
It's constant attention to it. It's as Richard says, praise for the staff when we've done it. Actually, that we've maintained it as sort of one of the top performers in the country on it, and actually what that means to patients. Actually, praise the staff for doing it, but actually what will that mean for patients? And it's a constant focus. You've got to go. Everyone's job is to get that next crew. We look at the screen, so we know they're coming. So we have an ambulance screen by the sort of nursing doctor in charge station, and so with the 6 crews inbound. Right, we need to make the space for the 6 crews. We know they're coming. Rather than going all 6 more have arrived, actually we should be making the space when they're on the way. And again, it's part of it is that. And I think the other thing is prioritisation.
Richard, any thoughts from you that we need to consider as well here?
Yeah, absolutely. I think we make it a fundamental part of the senior nurses' leadership roles, responsibilities. My staff think I'm obsessed with this, and to a certain degree I am. But I've always been an advocate for the old people. The old people are the people that's probably going to use this ambulances more than anybody else. They're vulnerable. They need looking after, and I think just that constant attention to it, but also installing it into them. This is a key part of your role as a senior nurse and a leader within the emergency department, and the junior staff as well. The junior staff, when they start putting it as part of their induction, raising it as an important part of emergency care and the emergency care pathway. Same with the doctors. Raise it at their junior doctor forums, tell them about it, and make them understand the connection to that little old lady at home who needs that ambulance.
So keep it as a top priority, really.
Absolutely,
is one of the key messages.
And credit to Richard, the reason this has changed is that 5 years ago we were sort of mid to sort of bottom quartile of the Midlands region in terms of ambulance turnaround times, and the staffing didn't change, the space didn't change. we used to have crew staff would see the patient with the crew, although with the crew they're not our patient yet, and the mindset change of that our patients, we want them now, is what's changed that. The staffing and space didn't change. It wasn't an investment or a space thing that changed it. It was a mindset change, and credit to Richard and the team for doing that. And the other way I think about it is, if ambulances are being delayed, it's the reverse of triage. Triage is about getting the sickest, frailest people seen soonest. If you were sick enough to need an ambulance or frail enough to need an ambulance and you wait longer, and if you walk in the door, that is the very reverse of triage, which is, and that's another thing to talk to staff about. It's our sickest patients, let's have them now.
That's great. And as we come to the end of our podcast, again, a final question for both of you. If you had to share your top tips with other people who are perhaps considering similar changes in their department, what would they be? And we'll start with you, Richard.
I think you have to own it. That's the first thing. This is not going to go away. If your department sees 100 ambulances a day, then ambulances are going to come, whether it's at 5, at sort of 9 in the morning when you really want them, or at 9 p.m. at night when you really don't want them. So they're going to come anyway. I think it's the ownership. You have to own this as a part of it. It's an essential part of the emergency care pathway, and you have to own it. And your team does, and you have to instill confidence in them to take the risks, push the boundaries, and take responsibility for the patients that are sat in the ambulance and are sat at home, and the reward and the pride in it. I take great pride in it, as I know Ben does, and it's great to be sort of sharing sort of our success with other people.
Thank you, Ben. Your top tip?
Yeah, I think it's as Richard, attention to detail on it, but actually it's marginal gains. It's not one thing that fixes it. It's actually the streaming to primary care, the streaming to STEC, the huddles. It's about doing lots of little things 1% better versus one big thing. And it's not really about space. It's not really about staffing. It's actually about that, and that's the thing that makes the detail, and it's adaptability. So what do we do when we're full? Well, we're going to have to make a different plan rather than going, we're full now, stop. And these are hard things for people, but actually I always think, what would you do? The test I've played now is, if it was my relative sat on the floor with a broken hip in a pile of urine in a freezing house, what would I do? And then you play that out in your head and do it.
Absolutely. Definitely something that requires some thinking. I'm absolutely certain of that. Thank you both very much for your time. It has been really helpful to hear about your journey, and I hope useful for colleagues who are listening to the podcast. We will hopefully join you with another podcast very, very soon. Thank you.